Okay, we are live. Thank you so much, web shadowers, for joining us today. Today we have the pleasure of hosting Dr. David Janiczek, an anesthesiologist. As always, please remember that the Google form will be posted in the comments section and our Instagram bio at the end, so you can all fill that out to get verification for this session today. With that being said, Dr. Janiczek, if you want to share your screen, you can get started whenever you're ready.
Thank you very much. All right. Well, thanks for joining us today. I'm really excited to talk about anesthesia, something that I've had an interest in for many years now, and it's finally coming to fruition. So, like was said before, my name is David. I'm a chief resident and one of the fourth-year anesthesia residents at the University of Illinois Chicago. I'm also the advisor for the Premed scene. If you guys have seen them on social media these days, check them out. They're doing a lot of great stuff for pre-meds and shadowing and opportunities and everything. And then also I'm founder of Get Admitted ND, which I'll get to a little bit at the end of the presentation. So let's move on. This is a little bit of an outline for what I'm going to talk about today. I got a lot of stuff to talk about, so let's kind of get started. So a little bit about myself. I'm originally from Bettendorf, Iowa. I then attended the University of Iowa for both undergraduate and medical school. I studied physiology at the University of Iowa for my undergraduate degree. And then I also had a business administration minor as well. So I came out to Chicago for residency, where I'm at the University of Illinois Chicago. And I'll be going down to Ochsner Health in New Orleans for a cardiothoracic anesthesia fellowship next summer. So we can talk a little bit more about fellowships later on in the presentation if you guys are interested. So my path to anesthesia actually started way back in high school. So I took an anatomy and physiology course as part of my high school curriculum, and I was able to shadow an anesthesiologist at a local hospital. And it really just blew me away, the role that they played in the operating room, the amazing things that they did, and the amount of physiology that they needed to know to do their job. So in college, like I said, I studied physiology and just fell in love with learning how the body works and manipulating it with pharmacology. I also worked as an anesthesia technician at the hospital in Iowa City, and that was a great experience. It put me in front of anesthesia residents, anesthesia attendings, and I really got to know kind of what the workings of an operating room setting are, and really confirmed my goals going into anesthesia. In medical school, just some anesthesia related experiences. I did a summer research fellowship in between my first and second year, where I studied ACE inhibitor impacts on the anesthesia and blood pressure, specifically after giving propofol and some other medicines at the beginning of the surgery. And then I did what's called an anesthesia externship in my fourth year of medical school. So basically, I would take call on the nights and weekends with the anesthesia team, and really learned a lot about doing things after hours in anesthesia. Sometimes you have to improvise, all those sorts of things. So it was a great experience. So why did I pick anesthesia? I think it's really important to kind of figure out what specialty you guys are interested in the future is determining what you're interested in. So basically, boiled down to, I was fascinated with human physiology and pharmacology, and learning how to manipulate the body with pharmacology. I also love the operating room environment. For those of you who have been in the operating room and enjoy it, you kind of know what I'm talking about. There's just something special about the operating room, and it's not for everyone, but if you really do enjoy it, then anesthesia is a great field for being in there. The ability to do procedures was really appealing to me. So you kind of get your hands dirty, so to speak. So you can do central lines. You put in IVs all the time. You do epidurals for labor anesthesia. All those sorts of things are really fun, and it kind of breaks up your day when you're able to do those. The other thing is you're able to work with different specialties on a daily basis. So one day I might be working with orthopedics. The other day I might be working with cardiothoracic surgeons, neurosurgeons, general surgeons. We work with everyone. And so it kind of keeps it a nice variety. One of the other things that really drew me to anesthesia was, my interventions have, an almost immediate physiologic impact. So the best example I can use is if a patient has low blood pressure in the operating room, I treat it. I know that I treated it because I gave the medicine myself, and then I can see the physiologic response on the monitors, which I'll kind of go through with what monitors should we look at and all that stuff later on. But I never wanted to be a physician that saw a patient in clinic and said, come back and see me in 3 months. I don't know if they're going to take the medicines I prescribe. I don't know if there's other factors that go into whether or not their medicine is going to work or if their health is going to improve. So anesthesia is kind of that immediate gratification that what you're doing is having an impact on the patient. And then lastly, very little continuity of care. So this could be viewed as a positive or a negative. I viewed it as a positive, sometimes it's tough. You meet some really nice patients that you wish you could see more often, but there's also a lot of patients that unfortunately you take care of once and then you don't necessarily have to ever take care of them again. And so it's kind of nice to have that short-term impact on a patient, and you're not seeing them for years and years and years down the line. So, all right, so let's dive into what is anesthesia. So really, anesthesia is made up of 4 pillars. So the first one is analgesia, so that's pain relief. And so that's one of the big things that we provide as anesthesiologists is pain relief during surgery, pain relief after surgery, those sorts of things. Secondly is paralysis. So another way to say this is muscle relaxation. So for many surgeries, we actually give medicines that relax the patient's muscles or paralyze them. And so, I'll talk about this later on, but then we have to, reverse this paralysis at the end of this procedure. So it is just a temporary thing that we give. And it's really cool, that we're able to do these sorts of things. Next up is amnesia. So basically the loss of memory. Patients don't really want to see or remember what their surgery was, or the environment or anything like that. And so we can provide medicines that basically knock out the memories for, whatever surgery time frame they have, whether it's an hour, whether it's 3 hours, 6 hours, whatever it takes, we can do that as well. And then lastly, you want to be unconscious for your surgeries. You don't want to be awake for, getting your gallbladder out or anything like that. So those are the 4 pillars. And then as you can see on the bottom of the screen here, there's a continuum. And this is exactly what I tell the patients before surgery when I talk to them. Basically, on one end of the spectrum, you have the awake state. So everyone understands that. We can provide some anesthesia in the awake state. This is called local or regional anesthesia. So local anesthesia is best accustomed to kind of what dentists do. So they provide local anesthesia in the mouth when they're working in there. We can do the same thing, for small surgeries. We can provide local anesthesia just to the area of the surgery and provide pain control there. Regional anesthesia is a field or a subspecialty of the anesthesia where we actually do nerve blocks. So we basically find the nerve that we're interested in blocking and inject a little bit of medicine around the nerve, and that basically knocks it, so to speak, asleep for a few hours, and it can provide really good pain control for patients. It's really used in orthopedic surgeries a lot, but it can be used in a variety of settings as well. All right, in the middle of the spectrum is what I would call sedated. So you've probably heard the term sedation before. This is usually done for minor procedures and procedures where you don't need to go all the way off of sleep. In the anesthesia world, sedation is often called monitored anesthesia care. And so people outside of anesthesia can provide sedation if they get a certificate, but if anesthesiologists are providing this level of anesthesia, it's usually called monitored anesthesia care. And then finally, on the far right of the spectrum, we have asleep. So this is what you think of as general anesthesia. This is the typical anesthesia that you get in the operating room for a variety of surgeries, and most of the time that's what you think of for anesthesia. So there's basically 3 phases of anesthesia that we think about during a procedure. So the first is called induction. So we accustom that to taking off, or an airplane taking off the runway. It's a very volatile time. Things can go wrong. Patients can, code, and then we have to do CPR in the operating room. It's a very tenuous time. And then the second phase is called maintenance. So this is accustomed to, when the plane's on autopilot, right? So the pilots are sitting back, they're watching Netflix or whatever they do in the cockpit, and basically the plane is flying itself. Anesthesia isn't 100% on autopilot, but for the most part, the most time, we don't have to do a ton of interventions in the middle of basic surgeries at least. And then lastly, we have Emergence. So this is accustomed to a plane landing. So once again, very tenuous. A lot of things can go wrong when a patient's emerging. And then what Emergence leads to is extubation, or taking the breathing tube out. So those are the three phases. I want to then kind of touch on, I'm not going to go through all these things, but basically the history of anesthesia is super interesting. So if you have a free afternoon sometime, you should really read about it. People have probably heard of nitrous oxide or laughing gas. Basically, that started back in the 1770s when a guy by the name of Joseph Priestley discovered nitrous. It was used for a long time until the 1840s when ether came around. And many of you have probably heard of the ether dome out in Boston, which is the first public use of ether for anesthesia. The history goes on. Basically the workhorses of anesthesia these days are fluorinated hydrocarbons. So compounds called enfluorine, which is no longer used, but isoflurane, sevoflurane, desflurane, all those sorts of things are still used today. And then the really interesting fact here is, propofol, which many of you have probably heard of, actually wasn't invented until 1977. So that's a relatively young drug in the scheme of things. So, and then just a note about muscle relaxants as well. So, what's a typical day like in anesthesia? This could be highly variable depending on what your practice is. If you're private practice, if you're in academics, what types of surgeries are you doing? Are you in an outpatient surgery center? Anything like that. So I basically boiled it down to, we start early, and sometimes we end early, but sometimes we work into the evening and night. So usually between 6 and 7 a.m. is when you arrive at the hospital. You set up your OR. So this would be a typical setup here on the left side of the screen, with multiple drugs, emergency drugs, those sorts of things. What I didn't picture here is all the airway supplies that we need to have to intubate patients and place the breathing tubes and everything like that. So once you visit with the first patient, usually the start of your actual day is between 7 and 8 a.m. And that's when the OR start running. And then, like I said, this can vary between hospitals and what your practice is. Usually in the middle of the morning, we get a morning break. That's one nice thing about anesthesia is we get breaks. We can go get coffee, get a snack, those sorts of things. And it actually really helps because if you stay in the operating room for 10 hours straight, you would get fatigued very quickly. So it's kind of nice to step out of the room every couple hours and get some short amount of rest. Usually in the middle of the day, we get a lunch, and then I put a wide range from 2 p.m. to 6 p.m. for being done for the day. Like I said, that can be highly variable based on your practice and how many surgeries you have that day. And then if you're on call, then typically it's a little bit later than that as well. So what is the path to being an anesthesiologist? So 4 years of undergrad, 4 years of med school, and then a 4-year residency. So the residency is based on, or broken up into kind of two portions. So the first year is the internship. This is your typical internship. Usually you rotate through different areas of the hospital. Most programs have a general surgery month or 2 months. You may work in the ED or the emergency department for a month. And then a lot of your time is spent, on the medicine floors, learning how to be a doctor, taking care of patients in more of a general sense. And then your postgraduate year, PGY 2 through 4 years, these are called the clinical anesthesia years, so the CA 1 through 3 years. So these are when you're actually learning anesthesia, and you're taking care of patients in the operating room, and learning what it takes to be an anesthesiologist. And then there's an optional 1-year fellowship. You don't have to do a fellowship for anesthesia, which is one of the great things about it. You can go get great jobs without a fellowship. But if you're interested in these areas, so cardiothoracic anesthesia is one of them, OB anesthesia, neuro anesthesia, chronic pain management, pediatric anesthesia, these are all options, and varying difficulties of getting into those. But there's a lot of different ways that you can become specialized in anesthesia, and it's it's a very good field for variety. you're interested in that. All right, so I want to talk about a case now. So unfortunately, if you were able to shadow me in person, I would show you the operating room and everything like that. Based on these days, we're gonna have to do it virtually. So here we go. All right, so just imagine you are a second-year resident or a first-year anesthesia resident, so a CA1. It's your first night on call. It's a Friday night, and you get a call from the OR control board that there's a add-on case that's about to start. So you wake up, you get yourself out of bed, and then you start to think about what you need to do next. So you go to you decide to go to the OR and set that up first. So the first question that pops into your head is, what supplies or equipment do you need to get started? So basically what you need is an anesthesia machine. Obviously, typically those stay in the operating room, so you're not moving those around for the most part. You need drugs, you need airway equipment, and anything emergency related that you may need, such as blood pressure medications, those sorts of things. So as you're setting up the OR, you start thinking about these questions. So what type of anesthesia will you provide? So if you go back to the screen where I kind of talked about the continuum, we have regional anesthesia on one end where the patient's awake, and then you have moderate anesthesia care in the middle, and then general anesthesia on the sleep side of the spectrum. So for this surgery, you're going to have to have the patient asleep, and so you'll have to do general anesthesia. So then, the next question that pops in your head is, do you need any additional IV access? Well, this is a maybe. It really depends on what IV access the patient comes with from the emergency room. For an appendectomy, it's probably not going to be a big deal in terms of blood loss, and so you probably don't need a ton of IV access. But if it's a more difficult case, definitely a cardiac surgery or a transplant surgery, then you're going to definitely need some more IV access. All right. So do you need an arterial line? So first of all, what is an arterial line? So an arterial line is a special type of IV that measures your blood pressure on a beat-to-beat basis. So we actually, instead of placing the catheter in a vein, like an IV, we actually place it in an artery. So typically it's in the radial artery in your wrist, but there's other places that we can place it as well. For this case, you probably don't need that. The patient's young and healthy, which we'll get to in a second, but you probably don't need an arterial line for this case. So what drugs do you need to draw up? So if you think about what I talked about before, the 4 pillars of anesthesia, so we need something to get the patient unconscious. That's first and foremost. So usually propofol is a good drug for that. That's kind of our go-to. Amnesia is the second pillar. How do we make this patient forget the time surrounding the surgery? Usually that's done with a medicine called Versed or midazolam. If you guys know what Xanax is, then it's very similar. It's basically an IV form of Xanax. So basically just relaxes the patient, and it also causes some amnesia, so they forget about what happens in the surgery. And then there's analgesia. So typically fentanyl is used a lot in operating rooms for pain control. There's a lot of other options out there, and with the opioid crisis and epidemic, we're trying to avoid opioids as much as possible. So there's other options. We have IV Tylenol. We have a medicine called Toradol or Ketorolac. Basically, that's an IV form of ibuprofen. So it's a non-steroidal anti-inflammatory. And then lastly, muscle paralysis. And so I'll talk about these more in detail in a minute, but there's drugs such as dexamethasone or rocuronium that we can use as well. So you get all those set up, all the drugs drawn up, and then your next question is, do you need antibiotics? So surgical site infections are a real thing, and so one way to prevent that is through the use of antibiotics. Most of the time we use ceftazoline or Ancef. That's kind of the workhorse. for us, but you know, it really depends on the surgery. You know, sometimes we use vancomycin, sometimes we use other antibiotics to cover whatever microbes might be involved in the surgery. So then, what are the patient's most recent labs? So, you know, you want to know, is the patient anemic? Is their hemoglobin 5, which would be very, very low? You know, do they have a high potassium? Do they have, you know, kidney disease and they have a high creatinine? All these things, you know, need to be looked at by the anesthesiologist and make sure that there's nothing outstanding that needs to be done before, you know, we take the patient to the operating room. And then since you're a resident, you know, what information is your attending going to ask you? So, you know, attending wants to know certain pieces of information, and, you know, they don't really necessarily want to know about, you know, other pieces. So it's a, you know, delicate balance between looking up the patient, you know, in enough detail that you know the answers to their questions, but highlighting the things that they, you know, want to know versus the things that they don't want to know. All right, so after you're set up, you look up the patient in the electronic medical record, or EMR. You find out this patient's a 19-year-old male. He's 75 kilograms and his BMI is 24. His HPI, or history of present illness, he had a sharp abdominal pain that started 2 days ago near the umbilicus, and now is in the right lower quadrant. He also endorses being nauseous and vomiting several times since the pain started. He is now spiking a fever as well, up to 102.1 degrees Fahrenheit today. In terms of his past medical history, he's pretty healthy. He had childhood asthma, but he no longer takes any inhalers for that. You don't know his surgical history because it's not reported in the notes in the EMR, so we can ask him about that. Family history-wise, really non-contributory. His mother had some diabetes. His father had high blood pressure or hypertension, high cholesterol or hyperlipidemia, and he was a little bit heavier, so he had some obesity. Social history-wise, this patient does not drink any ethanol or alcohol. He smokes no tobacco, but he does smoke marijuana daily, and he denies any other illicit drug use, such as cocaine or heroin, which are the big ones that anesthesiologists really care about. So now you go see the patient. So besides confirming the information in the chart, there's a few questions we really focus on as anesthesiologists. So basically we ask, is there any previous history of anesthesia for the patient? If so, are there any complications? You know, the complications could include nausea, vomiting after surgery, or, you know, even worse, you know, maybe they needed the breathing tube for a couple days after surgery. Maybe they didn't wake up right. Anything like that, you know, we would want to know about ahead of time. The next question is any family history of anesthetic complications. So the big one that we're looking for here is a condition called malignant hypothermia, which is a very dangerous and deadly condition. It is a familial disease where basically certain anesthetics that we give, mainly one of the muscle relaxants and then also one of the inhaled anesthetics, can cause a muscle rigidity in these patients, and they can often die from other complications that happen from malignant hypothermia. As the name suggests, it also causes their body temperature to go very, very high, and they get very, very sick quickly. So we want to know about this ahead of time because there's precautions we can take to avoid these triggering substances. The next question, you know, we want to know any allergies to medicine. Obviously, we don't want to give a patient something that they're allergic to. So we want to make sure that we confirm those things ahead of time, and don't just rely on the chart to, you know, report those findings. Another big question we ask is, when's the last time they had anything to eat or drink, or, you know, PO intake? Basically, anytime we put a patient to sleep, there's a risk for aspiration. So basically stomach contents coming up through the esophagus and going back down into the trachea and into the lungs. So that is definitely something we want to avoid. It can cause a really nasty pneumonia if this happens. And so we want to know what, you know, when was their last meal, when was the last time they drank any fluids, anything like that. And then we also do a quick review of systems. So, you know, we go basically head to toe, make sure, you know, they've never had any issues with the major organ systems, you know, neurologically, cardiovascularly, respiratory-wise, kidney function-wise, anything like that. We just want to make sure we know everything about that patient from a medical history perspective. So physical exam is very important from an anesthesia perspective, and the most important physical exam that we can do is the airway exam. So what you see on the screen here is one way that we classify the airway of a patient. It's called the Mallampati classification. So basically, class 1 is the best, class 4 is the worst. And so as you can see, a class 1 airway is got a lot of room in here. You can see all of the uvula, you can see all of the tonsillar pillars at the back of the mouth, and you could just tell there's a lot of space there. On the contrary, class 4, you don't see any of those structures really. You really just see the palate. Maybe they have a large tongue that's obstructing the view. All these things lead to kind of a more difficult airway. In between those two extremes is class 2 and class 3. As you can see, class 2 looks more like class 1, and class 3 looks more like class 4. And so basically, it's just varying degrees of obstruction or possible obstruction to visualizing their airway. Luckily for us, our patient has a class 1 airway, so it's the best. Typically, class 1 airways are found in the younger, healthier patients, but it's not a 100% correlation there. Another way we can look at the airway is through 2 other measures called the thyromental distance, or TMD. So basically, from this picture, you can see this patient is extending their neck to the sky, and we're basically measuring the distance from the tip of the mentum or the chin to the tip of the thyroid cartilage. And so we can come up with a number either in finger breadth or centimeters. And so the shorter the TMD, often the more difficult the airway is. And then also mouth opening plays a role. So mouth opening is very important. If the patient can't open their mouth, it's very hard to get a breathing tube in. If they can open their mouth very widely, then it's generally easier to get the breathing tube in, and we're less concerned about it. So other physical exam findings that are really important to us, cardiac-wise, we definitely want to know what their heart rate is and what rhythm they're in. So if the patient's in normal sinus rhythm versus atrial fibrillation versus another type of heart rhythm, because under anesthesia the heart rhythm can change. And so if the heart rhythm were to change under anesthesia, we want to know where we started so that we know when the change happens, and we can intervene quickly. We also want to know about any murmurs that we listen to, and that can give us ideas, about their heart in general. Respiratory-wise, we definitely want to listen to their lung sounds, and make sure, maybe they're brewing a pneumonia or, something like that we don't want to, make worse by putting them under general anesthesia. We also want to know, what their lung sound is like when they're breathing on their own versus, when we put them on a ventilator, this is obviously going to change. So we want to know what their lungs sound like at baseline. And then lastly, we want to take a look at their IV access. So like I kind of alluded to earlier, if they come to the emergency room or they come to the operating room with, a poor IV, maybe it's not even working anymore, then obviously we have to replace that before we take them to the operating room. Versus if they have a nice working IV, we can put them off to sleep. And even if we have to get other IVs in the operating room, at least we have one to start with. So that definitely saves us some time and in trouble. So next we come up with a plan. So I talked about this already. We call it premedication. So basically midazolam or Versed. So this bottle right here with the orange top. So that basically is going to provide some amnesia. This isn't really used to put patients to sleep. It doesn't really cause an unconscious state or anything like that. It's really used as anxiolysis or basically helping patients with their anxiety before surgery, and then causing some amnesia on the back end. So induction. So if you remember, induction is the time when the plane is taking off. In anesthesia terms, that's when we're getting the patient off to sleep. So for the most part, we use an IV induction, so intravenous induction. There's other ways to induce patients. So in kids, we actually use a inhaled induction often, because often they come to the operating room without an IV. So what we have to do is we basically use a little nitrous oxide, and then one of the inhaled anesthetics, and we basically let them breathe that in until they fall asleep, and then we put an IV in after they're asleep, and then we can use whatever medicines we want to keep them asleep. So induction, typically, we give some fentanyl, we give some propofol, and then for this patient, we're going to give succinylcholine. So this is what's called a depolarizing neuromuscular blocker. So really, it's just one class of the neuromuscular blockers or neuromuscular relaxing drugs that we use. It's short acting, so it only lasts about 5 to 7 minutes. Its onset is about 30 seconds. So it's a very quick drug, and it's a really good drug for these patients. The one thing that, if this patient's been nauseous and vomiting for the past couple of days, we don't want any of their stomach contents to come up during, intubation. So if we can get them, neuromuscularly relaxed very quickly, then we can get the breathing tube in quickly, and then we protect their airway from that aspiration risk. And then finally, after we give these medicines and induce the patient, they're asleep, then it's time for intubation. So I want to cover how do we intubate. So it's really interesting. We have a variety of tools, and it's one of the fun parts of anesthesia is all the kind of the tools and fun stuff we get to play with. So I want to draw your attention to this first one down here in the middle. So that's our classic laryngoscope. So basically, I'll show you in the next slide how it works. But basically, it's a battery operated light source with a little, we call it a blade. It's actually not sharp. There's nothing, you're not going to cut anything with it. But we call it a blade because it will move the tongue out of the way. So you can see that this one's curved in nature. In the picture in the bottom left, you can see we have curved ones, and then we also have straight ones. There's different applications for both. Some people have a preference whether or not they want to use the curved or the straight. At the end of the day, it really doesn't matter as long as you can get the breathing tube in. In the top left corner, you can see what's called a video laryngoscope. So this brand name is called GlideScope. There's a bunch of different brand names out there. But basically what this does is it allows us to see a video screen view of the larynx and the vocal cords, because that's where we place the breathing tube when we intubate a patient. So basically when we're intubating, we aim for this, this structure right here. And that's behind that structure is the trachea. So that's where we want to place our breathing tube. One of the other models of that is in the top right corner. This is called a McGrath. Video laryngoscope is a lot more portable. You can put it in your pocket and then take it to the ICU, take it anywhere you need it to go. And it's a lot easier to use than lugging around a GlideScope. And then finally in the bottom right corner, this is called a fiber optic. So this is another way we intubate the patient. So basically it's this long skinny tube hooked up, it's got a little fiber optic camera at the end, and the anesthesia provider is looking at this screen and guiding the breathing tube into the trachea that way. So if a patient has, a large tongue, maybe their neck is immobile, maybe they have a cervical fusion from a prior surgery, something like that, and we can't really move their neck around, then, we may use a fiber optic to kind of navigate the tube into place. So these are, just some of the toys we have to intubate a patient. So in the screen, this provider is doing what's called direct laryngoscopy. So basically, they're holding a laryngoscope in their left hand. They're holding a breathing tube in their right hand, and they're looking in the mouth and trying to find. I'll show you guys a view in the next couple slides of what they're looking at. But basically, this is the technique that has been taught for years and years on how to intubate patients before the advent of video laryngoscopes, which most people use today. But a lot of us still use the direct laryngoscopy as well. So as you can see from the picture on the right, we insert the laryngoscope into a spot called the vallecula. And so this little area right here is the vallecula. It's right before the epiglottis. And then basically what we do, is we guide the breathing tube into the trachea. And as you can see, the esophagus is right there. So often what happens when new anesthesia residents are first training is that they will actually put the breathing tube in the trachea by mistake. And so they start ventilating and they actually start ventilating the stomach. And so that's definitely not what we want. And so we have to quickly recognize that and take the breathing tube out and place it, in the correct location in the trachea for it to actually do what we want it to do. So this is the view that I was talking about. So as that provider was looking into the mouth, this is what they were looking at. So this is another way that we kind of grade the patient's airway. And so this is called the Cormax Lahane view. And so once again, it's 1 through 4. 1 is the best view, 4 is the worst view. And so as you can see, this is the grade 1 view. You can see all the vocal cords, lots of space in here. You should be able to see, the epiglottis is right here, kind of out of the way. And this is kind of a straight shot to the airway. So these are the best views. These are, very sought after. And so you really want to make sure that you can get this sort of view to increase your chances of a successful intubation. Moving on to grade 2, as you can see, the epiglottis is now moved into the path of the breathing tube placement. You can still see a little bit of vocal cord underneath the epiglottis. And then there's the arytenoid cartilages, or the arytenoid cartilage down here at the bottom. So this is still a pretty good view. You can see that you can still place a breathing tube right underneath the epiglottis, and typically you're pretty successful. Moving on to grade 3, as you can see, you don't really see any of the structures of the vocal cords or anything, right? You just see the epiglottis there. These are very difficult, intubations to do because you can't really see anything. So if I was going to do a direct laryngoscopy and I saw this view, I would maybe then switch to, maybe a video laryngoscope would provide me a better view, or even a fiber optic at that point. And then finally, grade 4, essentially all you see is the tongue. And so this structure right here is the tongue. Somewhere down here is the vocal cords, but you can't really see them at this point. This is a very bad view to intubate a patient. So if you get this view and you're intubating, you have to change something because this is near impossible to intubate with this view, based on the image I just showed you where the esophagus is right next to the trachea. If you tried to sneak a breathing tube underneath the tongue here, you could very easily put it in the esophagus without noticing. So luckily our patient is young and healthy. They're thin, so they have a grade 1 view, which is the best. And so the intubation shouldn't be too bad. All right, so you got the patient intubated. So now what do we do? So, the old saying is that, anesthesiologists always play sudoku, they play crosswords, or they do their stocks in the operating room. Well, that's not completely true. And so definitely, they don't just intubate the patient and then, move on to these other things. So what you need to do is, you may have to start antibiotics. So it's really important to get antibiotics in near the start of the surgery. So as soon as you can get the antibiotics in, then it's better. So before, we were using IV in anesthesia. And so now that you got the breathing tube in place, we can use what's called inhaled anesthetics. So the sevoflurane, desflurane, those sorts of things. So you want to make sure you turn that on because your propofol that you give is going to wear off within about 10 minutes or so. And so, then the patient may wake up with the breathing tube in. So you really want to make sure you remember to turn your inhaled anesthetic on and make sure you keep the patient asleep. Positioning may be an issue. Maybe for the surgery, they need the positioning different than what you needed for the intubation. So you may have to change things around after the patient's intubated. So we used succinylcholine before to intubate this patient, and now we need something longer acting. So we need neuromuscular relaxation, and we're going to use rocuronium. There's other options for neuromuscular relaxation, but we choose rocuronium because we're the most, that's the one we're most familiar with, and it's pretty readily available. And then the question pops into your head: do you need more IV access? Do you need an arterial line? A central line, all those sorts of things. For this case, you don't, so you move on. But for some cases, you will have to think about those things. So is it time for sudoku yet? Well, not quite. So as the surgeon starting the surgery, the patient's blood pressure goes from a nice 126/78 to 79/49 millimeters of mercury. So this is a big drop, and so this is not good for the patient. It's not good for the anesthesiologist stress level. And so basically what you need to do is diagnose this problem very quickly, figure out what happened, and more importantly, what are you going to do to fix it? So basically the long story short is something called insufflation. So if you remember from the stem of the case, this is a laparoscopic appendectomy. So basically for laparoscopic cases, that means the surgeons put tiny camera in the patient's abdomen, and then they use other tools to take out the appendix. And so one thing that they need to do in order to accomplish this type of surgery is they basically need to fill the abdomen with carbon dioxide. So they pump carbon dioxide in, that's called insufflation. And then what this does is it basically puts pressure on the inferior vena cava, or IVC. It drops preload to the heart, drops blood flow back to the heart, and you get a drop in blood pressure. So what can you do to fix it? Basically, you can start, giving more IV fluid. So you just open your fluids wide open, make sure you're giving enough of those. Medications are a huge role in it, play a huge role in this. So pressors. So basically, pressors are blood pressure medications. Phenylephrine, norepinephrine. If you really need it, epinephrine. Those all work for blood pressure management. And then one thing you can do is ask the surgeon to decrease the insufflation pressure. And so that will decrease the pressure on the IVC, increase blood flow back to the heart, and your blood pressure will go up. So based on all of this, what do we actually do during surgery? So this is one screen, or a type of screen that's very common in the operating room environment. So basically, this is our vital screen. So as you can see across the top, we have an electrocardiogram, or ECG. This gives us a heart rate. So that's really important. We need to know the heart rate of the patient during the procedure. The next waveform is a SpO2 waveform. So that's the amount of oxygen, or the percent oxygen saturation in the blood. As you can see, 95% for this patient. And then lastly, carbon dioxide, or CO2. So basically what we need to do is we need to measure how much CO2 the patient is breathing out. And so this is called end-tidal CO2. So basically this is measured as the expiratory gases from the patient. And so then the other thing is called NIBP, or non-invasive blood pressure. And so that's basically with the blood pressure cuff on the patient. These other measures are very important as well. So the respiratory rate, often we set this with the ventilator settings, which I'll show you in the next picture. But if the patient's on a spontaneous breathing mode, which is common in the operating room, then they may be setting their own respiratory rate. And then lastly, temperature. So one big thing in anesthesia is keeping the patient warm. So typically operating rooms are very cold. The surgeons get hot. Other staff get hot in the operating room. And so usually, the temperature is 60, 65 degrees, something like that. So patients can't keep themselves warm. So we have to keep them warm ourselves. And so there's special ways to do that, which is outside the scope of this talk. So this is another big screen that we often look at. This is associated with the ventilator. And so for general anesthesia, we knock out the patient's ability to breathe, especially with neuromuscular relaxation. And therefore, we need to breathe for them. So that's why we have a ventilator. And so basically, there's a bunch of settings you can do. So, we set the percent oxygen that the patient's breathing. We set, the respiratory rate. We can set the tidal volume, or how much each breath is in terms of milliliters. And then we can also set other parameters for the ventilator. And basically what the ventilator does is it gives whatever tidal volume we set. So here it's 600 milliliters at a respiratory rate of 12. And then, we get numbers back. So we get an end-tidal CO2 number back. We get a minute ventilation, which is basically tidal volume times frequency. And we can see peak airway pressures, all those sorts of things. This is what really keeps us busy during the procedures. We're always scanning these monitors, making sure nothing looks out of place, and it's exactly what we're hoping that is happening. So we don't have time for sudoku, we don't have time for stocks, all those sorts of myths. Maybe someday down the road we'll do those when we're a little bit more experienced, but definitely younger anesthesiologists don't do that. So. All right, so let's fast forward to the end of the case. As you can see from this plane landing, it's once again that tenuous time called emergence. So basically, we turn off our inhaled anesthetic. The goal is that we extubate the patient immediately after the last stitch, or whenever the wound is bandaged. So this inhaled anesthetic takes some time to basically get expired by the patient. And so it's not just an instant thing. Sometimes it can take 20 minutes for the patient to breathe off all the inhaled anesthetic, sometimes longer, depending on how long the patient's been under general anesthesia. The other big thing is if we've given neuromuscular blockade, such as rocuronium, we definitely have to reverse it. And so we can't just let the patient, stay paralyzed, or they're not going to breathe on their own very well. So we've done all that. We extubated the patient. He woke up beautifully. So what do we do after the case? So we transfer the patient to the post-anesthesia care unit, or also called PACU. You basically have to make sure the vitals are stable and the pain control is adequate, and then assess for any post-op nausea vomiting, as that's a common side effect of anesthesia. For this case, the patient's young and healthy. They could be discharged on the, that same day. Because it's late in the evening, early in the morning, if you remember the patient's, surgery was at 1 a.m., then, maybe they'll get discharged later in the day. If there are no more cases for the moment, then basically your night is great, and you can go back to bed and wait for the next phone call. So kind of a summary of anesthesia. It's a great, exciting field with tons of variety, procedures, and tons of physiology and pharmacology. So if you love those two fields, anesthesia is a great great specialty for you. One of my attendings told me this one time, anesthesia is 97% chill and 3% complete chaos. So if that sounds great to you, then anesthesia is, the field that you should choose. I've heard this anywhere from 95% and 5% to 99% and 1%. But basically the point is, most of the time everything goes very well. Anesthesia is very safe, and it's just getting safer by the day. But there's still some events that do happen in the operating room that we can't change and we can't predict. And so honestly, that's where the complete chaos comes into place. So some downsides of anesthesia: hours can be long, exhausting, stressful at times. If you're into continuity of care and developing relationships with patients over the long term, anesthesia is not really the field for you. The one caveat of that is chronic pain management, in which it's a little bit more clinic-based. You see patients over months to years. You develop a treatment plan, get their pain under control. You may do some procedures on them to help with their pain. But outside of that, for the most part, anesthesia, you may see a patient once, maybe twice in your career, and you kind of move on to the next one. The other downside that I mentioned is, your practice can be determined by surgeons or the hospital that you work in. And so if you work in a hospital that's predominantly orthopedic surgeons, obviously you're going to do a lot of orthopedic anesthesia. If you work in a hospital that's primarily cardiac in nature, then you're going to work with cardiac surgeons and so on and so forth. So while this does provide a great variety, if you're in a hospital that you don't really like, working with that type of surgeon, then it's not going to be as fun as it could be. So with that, I'd like to open it up for any questions, and thank you guys for listening.
Dr. Janiczek, I've typed some questions into the chat box.
Yeah, okay. So I'll just kind of go through them one by one. So the first one I see is, what are the odds of anesthesia awareness during surgery? So honestly, this really depends on a lot of things. the bottom line is it's very low, and the risk increases when if the patient's not doing so well. So maybe they're having very low blood pressure. We kind of have to go down in the anesthesia, because one of the side effects of our inhaled anesthetics is that it does cause low blood pressure, or it can. And so if that becomes an issue, then we kind of have to go down in the anesthesia, and this can lead to an increase in awareness. Otherwise, I don't know the exact number. It's probably less than 1% in terms of awareness during a typical anesthetic. So is there an anesthesia assistant by your side during surgery? And so this really depends on whether or not you're in an academic setting or a private practice setting. So in private practice settings, then often as the anesthesiologist, then you could either do your own case, or you could be working with what's called a certified registered nurse anesthetist, or a CRNA. And so what those are nurses that have gone to nursing school. They've done some critical care nursing, and then they go back to a specialized school called CRNA school, where they learn the ropes of anesthesia, and then they provide care in the kind of the community setting for surgeries. And so as the anesthesiologist working with CRNAs, what would happen is you would be supervising up to 4 or 5 maybe CRNAs at one time in different rooms, and then you kind of just bounce back and forth between the different rooms and make sure that everything's going well. If you're in a private practice setting where you're doing your own cases, then you sit in your own room, and you provide all the anesthesia, you intubate the patient, you put the IVs in, all those sorts of things, and there's really no assistance for that. You just you do everything yourself. So I would say that it really depends on your circumstances. So the next question: how long does it take for an anesthesiologist to prepare the OR? So as it depends on where you're at in your career. Obviously, as senior anesthesiologist, it takes a very short amount of time. Maybe 5-10 minutes. For a junior resident just starting out, they may take half hour, 45 minutes to set up their room. And then, as you go through residency, you find little tricks to help set up your room quicker. And probably the average is 10 to 15 minutes, I'd say. You can definitely cut down on some of the timing as you get more experience. If there's an emergency and a patient needs surgery ASAP, how do you accommodate for the malignant hypothermia and the eating, drinking? So the malignant hypothermia, basically we just ask them. It's a very rare disorder, honestly. So you don't really face many patients with, family history of malignant hypothermia. In terms of eating and drinking, obviously we want them to have stopped those activities as far away from the surgery as possible. And so there's guidelines set forth for anesthesiologists. So clear liquids is now 2 hours. So we ask that patients stop drinking clear liquids 2 hours before surgery. Typically a small meal is 6 hours, and then a heavy meal is 8 hours. If it's a true emergency, then we talk to the surgeons. We explain to them what the risks are of doing this surgery. And if the surgeon says this has to be done now, we explain to the surgeons the risks, we explain to the patient the risks, and then we document in the medical record that we had these conversations. And there's ways to get around it in terms of, we could do what's called a rapid sequence induction. So basically the induction process is much shorter, and we get the breathing tube in faster. And that reduces the chance of having an aspiration event from, any food or liquid that's sitting in the stomach. And so there are times when, we can't follow those fasting guidelines to the T. And so we have to just kind of make do and, hope that, the patient doesn't aspirate when we intubate them. So the next question I see is, do you trust the patient completely when they tell you about their drug or substance use? What if there are complications that come up because they didn't tell you truthfully? Yeah, so that's a big thing is, trying to trust the patient. It's hard at times. And so, we kind of have to just explain to them the risks And so one thing that's, one substance abuse that's very important to us is cocaine. So if we take a patient to the operating room who is under the influence of cocaine, when they get anesthesia, it can cause a very profound hypertensive response. So their blood pressure can shoot through the roof. This leads to a possibility of stroke, seizures, heart attacks, all those sorts of things. And so basically we just tell them. And so sometimes being blunt and saying these are the risks, can lead to a patient owning up to, hey, doc, I used cocaine 2 days ago, or hey, I used it 2 hours ago. And so I've definitely had situations where, the patient's not forthcoming with information right away. But by the end of the interview where I'm, talking to them, I tell them all the risks. And then, if they have a substance abuse history, kind of makes us more aware of the situation. If there's no mention of that at all, then we kind of take them for the word and try to trust them. In terms of, what if there are complications? This is where documenting ahead of time becomes a very, defensive maneuver in medicine. And so if you have any inclination that, something bad might happen, especially in anesthesia or surgery in general, if you document that you talk to the patient about the risks and, you document your conversations to the best of your abilities, then, later on, if something were to happen, it would be more defensible in court. And so, unfortunately, that's the way that medicine has gone a lot of the time these days is, how do I not get sued? It kind of goes through your mind a lot. And anesthesia, definitely that goes through our mind, just because it's a high rate of lawsuit field. And so really just document everything that you can is what I would say. So what did you do as an anesthesia tech? So basically, I turned over the operating rooms. So in between every surgery, the breathing circuit has to be changed. If the next surgery requires any special equipment, if the anesthesia supplies need to be restocked, I basically took care of all of that. And in return for all of that, I would talk with the residents at that residency program. I would talk to some of the attendings. Really just kind of talk to anyone that would, listen to me at that point. So let's see, does doing a fellowship decrease the variety of cases an anesthesiologist sees? Yes and no. So it really depends on what fellowship you do. You could always just be a general anesthesiologist. And so no fellowship is required. You can just be a general anesthesiologist. For me, I'm doing cardiac anesthesia. And so, will I see less, orthopedics? Will I see less, OB anesthesiology? Yes, probably. But that's kind of a choice you make. And so if you don't want to limit yourself in variety, then you don't have to do a fellowship. You can just go practice as a general anesthesiologist and make a very good career out of it, make a very good living. And so it's really just if you're interested in that certain fellowship, then that's when you should do the fellowship. How do you see your field changing in the next 10 years? That's a great question. The biggest thing that I've seen, over the last 10 years is CRNAs are definitely increasing in number. And they're, you'll read a lot online about CRNAs taking over the field of anesthesia. I don't foresee that happening. I would be more worried about AI and, kind of that sort of aspect of medicine, and specifically anesthesia taking over. And so recognizing patterns in, vital signs before something bad happens and, alerting either alerting the provider or in the end making, kind of an automatic system to control those things. I don't think that's going to happen in the next 10 years. But I think eventually that is kind of the way that anesthesia is going. The other thing that I would say is we haven't really had a lot of inventions in the last 15, 20 years in anesthesia, still using propofol, which was, created in the 1970s. I guess the newest, biggest drug that we've come out with is called sugammadex, which is a medicine that reverses neuromuscular relaxation quicker than the old drugs we used to use. But in terms of innovation, we haven't had a whole lot. And so, maybe a new drug that comes out, and hopefully that changes the landscape of anesthesia. Next question, would an anesthesiologist be the one to prescribe post-op meds for pain management? That's a great question. So in the immediate post-op period, if a patient's in the PACU or the post-anesthesia care unit, then that's typically on the anesthesiologist to prescribe. Anything beyond that is typically the primary team. So if they were a general surgery patient, then the general surgery team would prescribe that. If they were an orthopedic patient, then it would be an orthopedic prescription. So it really just depends on the setting, we don't prescribe. Anesthesiologists don't typically prescribe opioids to go home on. We don't just prescribe any real medications to leave the hospital on. So in terms of post-op pain management, it's really just the immediate post-op period. So when they're in the post-anesthesia care unit, that's when we really, we do prescribe some meds, but nothing to go home on. The next question, have you ever made a mistake during a surgery, and how did you deal with the outcome? Yeah, I mean, we always make mistakes, whether they're small mistakes or large mistakes. Small mistakes, maybe giving the wrong dose, maybe I gave too much medicine, and the patient's blood pressure went down more than I wanted it to. So, I just gave some other medicine and kind of balance things out. Bigger mistakes include giving the wrong medicine. And so, that is one thing that does happen. Unfortunately, not frequently, but, often enough that it can be an issue. And so, one big thing that comes up in these situations is, the little mistakes that don't, if I gave a little bit too much medicine, the patient got, some low blood pressure and I treated it and everything was fine. Those things I usually don't, I wouldn't necessarily tell the family afterwards. That's just kind of part of anesthesia. You're always titrating medicine, giving a little bit more, giving a little bit more. But if it was a medication error, then that's something that needs to be disclosed to the family and the patient typically. And so for one instance, the patient, I remember the patient was allergic to a certain type of antibiotic. It was not documented clearly in the electronic medical record, and the patient didn't know about it. And so, we gave that antibiotic, and luckily nothing bad happened. The patient did fine. But it's just better to disclose those things afterwards to the patient, to the family members, all those sorts of individuals. And what it taught me was, you just have to be, very vigilant with patient care, and especially in anesthesia, because it's such an acute setting. Mistakes happen, but mistakes can be, quite catastrophic. So it can be tough sometimes to deal with those things. How do you balance your work and personal life? So that's a great question. So as a resident, it's a little bit worse than, when you're done with residency as an attending. So anesthesia, luckily, is a pretty good work-life balance field. For the most part, we work maybe, in residency, we work about 60 hours a week at my program. Other programs definitely work more. So you kind of have to feel that out during the residency application process. But in terms of work-life balance as an attending, I think most anesthesiologists have, pretty good work-life balance. You do start work early. So, like I said, maybe 6 a.m., sometimes earlier, but then oftentimes you're out in the afternoon. You're done with the surgeries for the day, maybe around 2 or 3 p.m. You still have some of the afternoon and all of the evening to kind of, hang out with loved ones, do whatever activities you enjoy outside of the hospital, those sorts of things. And so as a resident, it's a little harder just because you're on call a lot. You're a little bit busier. And so that work-life balance can be tough. You just kind of have to set aside time and make a schedule and, stick to it. Say, Saturday, I'm going to do this, this, and this, and spend time with this person, and this person, and make sure that, you follow through on those things. and maintain your kind of your mental well-being, if you will. So that looks like all the questions. I just have one last slide. So basically, how can I help you in the future? So you guys can check out my website, www.getadmittedmd.com/services. That goes over kind of what I can help you with your application. And then later this fall, I'm coming out with a medical school application boot camp. This will allow you guys to kind of go through all of the content that I'm preparing at a pace that you guys would like. So I'm bundling all of the knowledge I gained. One thing I did not mention earlier was I spent some time on a medical school admissions committee when I was a medical student. So I reviewed every single type of application you've seen. So I'm bundling all this information and putting it in a online course. So if you're interested, please sign up for this mailing list. This will give you access to me, and I'll give you updates about the course, how to contact me. The other thing I didn't put on here is I'm also on Instagram it's at getadmittedmd. Reach out to me, ask me any questions you want. I'm always into answering questions. I'm really here to help you guys because I understand that this is a very tough process to get through, the medical school application, through medical school, into residency. All those things are very difficult. So thank you guys for listening. I really appreciate it. And I hope to talk to you guys soon.
Thank you so much, Dr. Janiczek. This was a wonderful presentation. I'm sure everyone learned so much. For everyone watching, the Google form has been posted in the comments and in our Instagram bio. So if you guys could fill that out so you get verification for attending this session. And once again, thank you so much, Dr. Janiczek.